Welcome to this video entitled Constipation. Let's look at a definition. Constipation does not have a single, generally agreed upon definition. Normal people pass at least 3 stools per week. Some of the definitions of constipation include fewer than 3 stools per week for women and 5 for men, despite a high residue diet or a period of greater than 3 days without a bowel movement. Straining at stool greater than 25% of the time and or 2 or fewer stools per week. Or straining at defecation and less than 1 stool daily with minimal effort. Let's now discuss the pathophysiology of constipation. 1. Constipation is not a disease but a symptom of an underlying disease or problem. 2. Disorders of the gastrointestinal tract, e.g., irritable bowel syndrome or diverticulitis, metabolic disorders, e.g., diabetes mellitus, or endocrine disorders, e.g., hypothyroidism, may cause constipation. 3. Constipation commonly results from a diet low in fiber or from use of constipating drugs such as opiates. Constipation may sometimes be psychogenic in origin. 4. Diseases or conditions that may cause constipation are a. Gastrointestinal disorders. Irritable bowel syndrome, diverticulitis, upper and lower gastrointestinal tract diseases, hemorrhoids, anal fissures, ulcerative proctitis, tumors, hernia, volvulus of the bowel, syphilis, tuberculosis, lymphogranuloma venerum, Hirschsprung's disease. B. Metabolic and endocrine disorders. Diabetes mellitus with neuropathy, hypothyroidism, panhypopituitarism, pheochromocytoma, hypercalcemia, enteric glucagons excess. C. Pregnancy. D. Neurogenic constipation. Head trauma, CNS tumors, spinal cord injury, cerebrospinal accidents, Parkinson's disease. E. Psychiatric disorders. F. Inappropriate bowel habits. G. Causes of drug-induced constipation are listed in Table 22.1. H. All opiate derivatives are associated with constipation, but the degree of intestinal inhibitory effects seems to differ between agents. Orally administered opiates appear to have greater inhibitory effect than parenterally administered agents. Oral codeine is well known as a potent antimotility agent. Pause the video and carefully scrutinize Table 22.1 summarizing drugs causing constipation before advancing to the next slide. We will now look at the clinical presentation of constipation. The laxative abuser may present with contradictory findings, sometimes diarrhea or weight loss. Laxative abusers may also have vomiting, abdominal pain, lassitude, thirst, edema, and bone pain, due to osteomalacia. With prolonged abuse, patients may have fluid and electrolyte imbalances, most commonly hyperkalemia, protein-losing gastroenteropathy with hypoalbuminemia, and syndromes resembling colitis. Laxative abusers frequently deny laxative use, as shown in Table 22.2. We will now look at the desired outcome. A major goal for treatment of constipation is prevention of constipation by alteration of lifestyle, particularly diet, to prevent further episodes of constipation. For acute constipation, the goal is to relieve symptoms and restore normal bowel function. Pause the video and carefully scrutinize Table 22.2 summarizing clinical presentation of constipation before advancing to the next slide. Next we will look at the treatment of constipation. Let's begin with a general approach to treatment. 1. The patient should be asked about the frequency of bowel movements and the chronicity of constipation. The patient should also be carefully questioned about usual diet and laxative regimens. Does the patient have a diet consistently deficient in high-fiber items and containing mainly highly refined foods? What laxatives or cathartics has the patient used to attempt relief of constipation? The patient should be questioned about other concurrent medications, with interest toward agents that might cause constipation. 2. General measures believed to be beneficial in managing constipation include dietary modification to increase the amount of fiber consumed daily, exercise, adjustment of bowel habits so that a regular and adequate time is made to respond to the urge to defecate, and increasing fluid intake. 3. If an underlying disease is recognized as the cause of constipation, attempts should be made to correct it. Gastrointestinal malignancies may be removed through a surgical resection. Endocrine and metabolic derangements are corrected by the appropriate methods. 4. Potential drug causes of constipation should be identified. For some medications, e.g., antacids, non-constipating alternatives exist. If no reasonable alternatives exist to the medication thought to be responsible for constipation, consideration should be given to lowering the dose. If a patient must remain on constipating medications, then more attention must be paid to general measures for prevention of constipation, as discussed in dietary modification and bulk-forming agents below. 5. In a small percentage of patients presenting with complaints of constipation, surgical procedures, such as intestinal resection, are necessary. Surgery is usually necessary with most colonic malignancies and with gastrointestinal obstruction from a number of causes. Next we will discuss dietary modification and bulk-forming agents. 1. The most important aspect of the therapy for constipation for the majority of patients is dietary modification to increase the amount of fiber consumed. Patients should be advised to include at least 10 grams of crude fiber in their daily diets. Fruits, vegetables, and cereals have the highest fiber content. 2. A trial of dietary modification with high fiber content should be continued for at least 1 month before effects on bowel function are determined. 3. The patient should be cautioned that abdominal distension and flatus may be particularly troublesome in the first few weeks, particularly with high bran consumption. We will now progress to the pharmacologic therapy of constipation. 1. The various types of laxatives are discussed in this section. The agents are divided into 3 general classifications listed below. 1. Those causing softening of feces in 1 to 3 days. Bulk-forming laxatives, DOCU sets, and lactulose. 2. Those that result in soft or semi-fluid stool in 6 to 12 hours, Bisacodyl and Senna. And 3. Those causing water evacuation in 1 to 6 hours, saline cathartics, castor oil, and polyethylene glycol electrolyte lavage solution. 2. Dosage recommendations for laxatives and cathartics are provided in Table 22.3. Pause the video and carefully scrutinize Table 22.3 summarizing dosage recommendations for laxatives and cathartics before advancing to the next slide. We will now focus on recommendations. 1. The basis for treatment and prevention of constipation should consist of bulk-forming agents in addition to dietary modifications that increase dietary fiber. 2. For most non-hospitalized persons with acute constipation, the infrequent use, less than every few weeks, of most laxative products is acceptable. However, before more potent laxative or cathartics are used, relatively simple measures may be tried. For example, Acute constipation may be relieved by the use of a tap water enema or a glycerin suppository. If neither is effective, the use of oral sorbitol, low doses of bisacodyl or senna, or saline laxatives, e.g., milk of magnesia, may provide relief. 3. If laxative treatment is required for longer than 1 week, the person should be advised to consult a physician to determine if there is an underlying cause of constipation that requires treatment with agents other than laxatives. 4. For some bedridden or geriatric patients, or others with chronic constipation, bulk-forming laxatives remain the first line of treatment, but the use of more potent laxatives may be required relatively frequently. Agents that may be used in these situations include milk of magnesia and lactulose. 5. In the hospitalized patient without gastrointestinal disease, constipation may be related to the use of general anesthesia and/or opiate substances. Most orally or rectally administered laxatives may be used. For prompt initiation of a bowel movement, a tap water enema or glycerin suppository is recommended, or milk of magnesia. 6. The approach to the treatment of constipation in infants and children should consider neurologic, metabolic, or anatomic abnormalities when constipation is a persistent problem. When not related to an underlying disease, the approach to constipation is similar to that in an adult. High-fiber diet should be emphasized. Next we will switch gears to emollient laxatives, i.e. docusets. 1. These surfactant agents, docusate in its various salts, work by facilitating the mixing of aqueous and fatty materials within the intestinal tract. They may increase water and electrolyte secretion in the small and large bowel. 2. These products result in a softening of stools within 1 to 3 days. 3. Emollient laxatives are not effective in treating constipation, but are used mainly to prevent constipation. They may be helpful in situations where straining at stool should be avoided, such as after recovery from myocardial infarction, with acute perianal disease, or after rectal surgery. 4. It is unlikely that these agents are effective in preventing constipation if major causative factors, e.g., heavy opiate use, uncorrected pathology, or inadequate dietary fiber, are not concurrently addressed. And now let's look at lubricants. 1. Mineral oil is the only lubricant laxative in routine use and acts by coating stool and allowing easier passage. It inhibits colonic absorption of water, thereby increasing stool weight and decreasing stool transit time. Generally, the effect on bowel function is noted after 2 or 3 days of use. 2. Mineral oil is helpful in situations similar to those suggested for docusates, to maintain a soft stool and avoid straining for relatively short periods of time, a few days to 2 weeks. 3. Mineral oil may be absorbed systemically and cause a foreign body reaction in lymphoid tissue. Also, in debilitated or recumbent patients, mineral oil may be aspirated, causing lipoid pneumonia. Let's now focus on lactulose and sorbitol. 1. Lactulose is a disaccharide that causes an osmotic effect retained in the colon. It is generally not recommended as a first-line agent for the treatment of constipation, because it is costly and not necessarily more effective than agents such as milk of magnesia. It may be justified as an alternative for acute constipation and has been found to be particularly useful in elderly patients. 2. Occasionally, the use of lactulose may result in flatulence, cramps, diarrhea, and electrolyte imbalances. 3. Sorbitol, a monosaccharide, has been recommended as a primary agent in the treatment of functional constipation in cognitively intact patients. It is as effective as lactulose and much less expensive. Next we will look at saline cathartics. 1. Saline cathartics are composed of relatively poorly absorbed ions such as magnesium, sulfate, phosphate, and citrate, which produce their effects primarily by osmotic action to retain fluid in the gastrointestinal tract. These agents may be given orally or rectally. 2. A bowel movement may result within a few hours of oral doses and in 1 hour or less after rectal administration. 3. These agents should be used primarily for acute evacuation of the bowel, which may be necessary before diagnostic examinations, after poisonings, and in conjunction with some anthelmintics to eliminate parasites. 4. Agents such as milk of magnesia, an 8% suspension of magnesium hydroxide, may be used occasionally, every few weeks, to treat constipation in otherwise healthy adults. 5. Saline cathartics should not be used on a routine basis to treat constipation. With fecal impactions, the enema formulations of these agents may be helpful. Let's now progress to castor oil. Castor oil is metabolized in the gastrointestinal tract through an active compound, ricinoleic acid, which stimulates secretory processes, decreases glucose absorption, and promotes intestinal motility, primarily in the small intestine. Castor oil usually results in a bowel movement within 1 to 3 hours of administration. Because the agent has such a strong purgative action, it should not be used for the routine treatment of constipation. And now we will consider glycerin. 1. This agent is usually administered as a 3-gram suppository and exerts its effect by osmotic action in the rectum. As with most agents given as suppositories, the onset of action is usually less than 30 minutes. 2. Glycerin is considered a safe laxative, although it may occasionally cause rectal irritation. Its use is acceptable on an intermittent basis for constipation, particularly in children. We will look at polyethylene glycol electrolyte lavage solution. 1. Whole bowel irrigation with polyethylene glycol electrolyte lavage solution has become popular for colon cleansing before diagnostic procedures or colorectal operations. 2. 4 liters of this solution is administered over 3 hours to obtain complete evacuation of the gastrointestinal tract. The solution is not recommended for the routine treatment of constipation, and its use should be avoided in patients with intestinal obstruction. Next we will focus on lubiprostone. Lubiprostone is a chloride channel activator that acts locally on the gut to accelerate genitourinary transit time and delay gastric emptying. It is approved for chronic idiopathic constipation in adults. The dose is 24 mg capsule twice daily with food. Lubiprostone may cause headache, diarrhea, and nausea. Finally, we will look at other agents. Tap water enemas may be used to treat simple constipation. The administration of 200 ml of water by enema to an adult often results in a bowel movement within 1.5 hours. Soap suds are no longer recommended for use in enemas, because their use may result in proctitis or colitis. Thank you.